Thanks very much, John, for that introduction, and thanks very much for the invitation to speak this evening about the treatments for ATTR amyloidosis. Following on from two fantastic talks, but really just so great to be in a position to be talking about treatments. When I joined the NAC back in 2009, and actually the increase in cases, Caroline, isn't anything to do with CMR or DPD. I joined in 2009, 2010, so I want to take credit. No, just joking. But we have seen a huge increase in the number of patients diagnosed over the last 10 years. But when I joined the NAC, we didn't really have any treatment. So yes, we could diagnose hereditary and wild type TTR amyloidosis, but weren't in a position to offer any significant treatment. So it gives me great pleasure to talk about where we have come to so far. And this is only just the beginning, I'm hoping. I'm hoping I'm going to go on to the next slide.
Yeah, just click it again on the slide, Carol.
Of course, it worked earlier.
Yeah.
There we are. Sorry about that. Okay, so what I'm going to talk about is, of course, the amazing disease-modifying treatments that are now available through the SMC in Scotland and through NICE in England and Wales and Northern Ireland, but also some supportive treatment that can be helpful to patients and carers. So we've heard from Caroline about how amyloidosis can cause heart failure. And we know that for many patients with heart failure, they become breathless and they develop fluid retention. And so to treat that fluid retention, so build up of fluid in the legs or even in the abdomen, in the lungs, we typically will use diuretics or water tablets. And furosemide is the most common diuretic that we prescribe. And we can start off at a low dose of, say, 40 milligrams and increase up to a huge dose of even 500 milligrams a day. Other diuretics can be added into furosemide, such as the MRA spironolactone, and they work well together to increase the effect of getting rid of that extra fluid, and the doses can be increased. But it's important that we monitor what we're doing with the diuretics and look at daily weights, look at fluid intake, look at the blood pressure so that we're not using too much in the way of diuretics and causing people to dry out, and looking at their kidney function through the blood test U and E's. And of course, sometimes tablets aren't enough on their own, and we sometimes require patients to be admitted to hospital for an injection of furosemide or indeed an infusion over 24 or 48 hours to get rid of that extra fluid. What can commonly be seen in this type of heart failure is that other common drugs used in other types of heart failure just aren't tolerated by patients with amyloidosis. And so many heart failure drugs such as ACE inhibitors or ARBs, which lower the blood pressure, or beta blockers, which lower the heart rate, can make patients feel much worse because it makes an already low blood pressure even lower, or a low heart rate even lower. So often we don't prescribe those drugs. That's not always the case, but it can sometimes be the case. So what advice would we give to our patients with heart failure? So it's all about the diet, it's all about diuretics, and it's all about the daily weights, so that the diuretic drugs are helpful at helping patients lose salt and water. But of course, if they have a big salt intake, then the effect can be completely lost. So the patient will have to look at what things to perhaps avoid, such as ready meals, crisps, bacon, cheese, and these other things listed in the slide. Important not to drink too much, so 1.5 litres to 2 litres a day is plenty. And to weigh yourself regularly. It doesn't need to be every day, but perhaps 2 or 3 times a week, just to make sure that the weight is stable. Sometimes it can be good to do that first thing after passing urine, still in your night clothes. Obviously, people's weights vary from day to day by a few pounds in most cases, but once you have swelling in your legs or swelling in your ankles, then actually you've probably gained about 3 or 4 kilograms. And so it's important to then think about perhaps increasing the amount of furosemide or whichever diuretic you're on, just to counter that before it becomes even more of a problem when you need to be required to be admitted to hospital. The specialist heart failure nurse can be invaluable in helping patients in advising about the diuretic dose. And they often have a helpline or telephone line where the patient can phone for advice to make those small adjustments to the diuretics before things get out of control. So hypotension or low blood pressure can be a problem. And so typically we will stop drugs that aren't necessary. So that might be an ACE inhibitor like ramipril, or an ARB like losartan, or a beta blocker like bisoprolol, or a calcium antagonist like amlodipine. Of course, this isn't for everybody across the board, but in some patients we need to do that. And in some patients, we'll even prescribe drugs that will increase the blood pressure to try and help that low blood pressure, such as midodrine or fludrocortisone. Symptoms of postural hypertension can be arising from the brain, where there's dizziness or lightheadedness. Patients may get visual changes, such as blurred or tunnel vision, or a blacking of their vision, just a decreasing level of awareness, leading on occasion to confusion. There may be loss of consciousness and blackouts, and some of you may have experienced that, where you fainted with or without warning. It can also cause pain across the back of the shoulders, which is what we call typically a coat hanger pain, or there can be pain in the lower back or indeed across the buttocks. Some people may experience angina type pain with postural hypotension, with pain across the chest. And some patients may just feel a general weakness or fatigue. When are these things likely to happen? Well, whenever there's an increased demand for blood for activities throughout the body. So it might happen in the morning as the blood volume is lower. So sudden movement from a lying or sitting position to standing can cause problems, so that the mechanisms that usually raise the blood pressure to prevent feeling faint or even blacking out aren't enough. It can be on exertion, when the increased demand from exercising muscles deprives the circulation to the brain, or after meals when the digestive system needs more blood, and then that reduces the supply to the brain. Alcohol can have a similar effect. It can happen after a period of inactivity, especially bed rest, or in the warmth of a centrally heated room. And I can't believe that I've still got my central heating on in May. It may be after a hot bath or a warm summer's day. The peripheral circulation is increased by dilating the blood vessels, thus lowering the blood pressure further. It might, of course, happen when you're going to the toilet and you're constipated, and that effect of straining, or even straining to pass urine. Illness can be from a cold or to more serious conditions, or indeed anxiety can cause overbreathing, which lowers the blood pressure. And as I've mentioned, a variety of drugs can lower the blood pressure. What strategies can we use to improve on those symptoms? Well, exercises such as leg exercises, flexing the ankle and foot up and down, or squeezing the calf muscle, gentle marching movements, or crossing or uncrossing the legs. And these can be used whilst patients in bed, sitting or standing. And in fact, if ever you have watched the Queen in long parades, whether it's Trooping the Colour or such like, then sometimes she can be seen to be going up onto her tiptoes and down again. And that's just to keep that circulation going, because the last thing she would want to do is to faint during these enormous parades. Other maneuvers can be crouching or squatting, so I don't think the Queen would do that. Or indeed that you can be using discrete techniques, so perhaps crouching over to pretend to tie your shoelace at the first signs of any symptoms before they get worse. So those are techniques that can be used with some of the symptoms that are commonly seen in hereditary ATTR amyloidosis. But what we know is that what we want to do is impact on the actual disease progression of this disease. And we know with time that the severity of the disease gets worse. But with early intervention, we can impact on that. And that's the aim of diagnosing patients earlier so that we can start treatment at an earlier stage and stop that progression of the symptoms. What are the strategies we use when we're looking at ATTR amyloidosis? Well, ATTR transthyretin is produced in the liver. Doesn't cause a problem with the liver function, but it is produced there. And so we can target, using drugs, production of TTR within the liver, and so reduce the supply of the amyloid precursor protein. If the precursor protein is produced and it's amyloid forming, then we can try to stabilize that amyloid forming protein in a structure that stops these amyloid fibrils from developing. If the amyloid actually does develop and is deposited on the organs, such as the heart and the nerves, then we can also try and tackle that by enhancing the removal of the existing amyloid. So all different areas are how we have tried to tackle the disease progression in ATTR amyloidosis. So the stabilizers I will talk about first. Diflunisal, many of you may have been on or are still on. It's an old-fashioned non-steroidal anti-inflammatory drug, which stabilizes the TTR protein in the structure to try and prevent amyloid fibrils from developing. Issues that we might see with diflunisal are related to the fact that it's a non-steroidal anti-inflammatory drug, so it can cause problems with the stomach and stomach ulcers. So we usually prescribe a tablet to try and counter that, such as omeprazole. It can cause fluid retention, which is obviously what we're trying to stop. And so we have to just watch that. And sometimes it can cause problems with the kidney function. In a trial looking at patients with hereditary ATTR amyloidosis with peripheral neuropathy compared with placebo, then diflunisal was seen to slow the progression of the disease. Tafamidis is also a TTR stabilizer, and the first trial of tafamidis was again in neuropathy, looking at patients with V30M, which is the commonest variant worldwide, but seen less commonly in the UK. And they had, the patients had peripheral neuropathy. And again, with tafamidis, there was seen to be a slowing of the progression of the disease. And in 2018, prior to that, as I said, there had been really very little in terms of treatment. And then it was a bit like a bus, where you wait for a bus to come along, and then 3 buses come all at once. And within the space of a month, 3 papers had been published in the very eminent New England Journal of Medicine, looking at 3 treatments for patients with hereditary ATTR amyloidosis, with peripheral neuropathy and with cardiomyopathy. So it was a very, very exciting time. I'm going to talk firstly about tafamidis, and I've told you about the trial looking at Tafamidis in peripheral neuropathy, but this was a trial looking at its effect on the heart, the ATTRACT trial. So patients had to have had a history of heart failure with a hospitalization for heart failure in the past or clinical evidence of heart failure. They had to have either wild type or hereditary ATTR, and they had to have evidence of an increased wall thickness in their heart. They had to have reasonable mobility, so they were able to walk more than 100 meters in 6 minutes. And they had to have reasonable exercise tolerance so that their breathlessness came on with exertion, but didn't come on with rest, just sitting. Patients were randomized to receive Tafamidis 80 milligrams orally or 20 milligrams orally, and the 20 milligram dose had been what had been used in the peripheral neuropathy trial, and that was compared with placebo. The primary endpoint, so what the researchers were trying to determine whether this would happen or not, was whether the Tafamidis would have an impact on all-cause mortality, so dying for any reason, or the frequency of cardiovascular-related hospitalizations within just under 3 years. And what was found in the ATTRACT trial was that when pulling the data from those patients on 20 milligrams or 80 milligrams, that they were 30% less likely to die over that period of time than patients on placebo. They were also less likely to be hospitalized. And when we look at the change in baseline in the 6-minute walk test, although patients did deteriorate, it was far less than those on placebo. And looking at the quality of life score in the Kansas City cardiac questionnaire, then their quality of life was much better than those on placebo over that 30-month period. So I've talked about the stabilization of this precursor protein, the TTR protein, but what we know about other types of amyloid, whether it's AA amyloid, which is related to a chronic inflammation in the body, or AL amyloid, which is where there is an abnormal production of plasma cells from the bone marrow, is that if we reduce the supply of that precursor protein, we can have an impact on disease progression. And in fact, we can then see disease regression. And so this is just looking at the impact of cutting the AA precursor protein, showing an improvement in survival, and cutting the light chain production and looking at improvement in survival. So can we see the same with TTR amyloid when we reduce the precursor protein? And that's exactly what the Apollo trial was looking to do, was cut the production of TTR within the liver. Patisiran, as many of you will know, is given by an intravenous infusion every 3 weeks. And the patients in the Apollo trial were randomized to receive either Patisiran or placebo. They had to be in stage 1 or stage 2. So we heard about the different stages earlier. So basically that they were able to walk either independently or with an aid such as a stick. There was a neurological impairment score looking at how much neuropathy that they had. And the primary endpoint in this trial was to look to see if there was a change in the mNIS+7 score from baseline at 18 months. And for those of you that have had this mNIS+7 score, you will know that it's quite a lengthy process and it's hated by most neurologists, I think, Katie, in terms of the time it takes to do the score. And it's a complex score looking at the sensory, motor, peripheral neuropathy, as well as autonomic neuropathy. And then were there other secondary endpoints? And what we can see here is that the purple line is patients who were on placebo, and the blue line, patients that were given Patisiran. And we can see that there was a rapid and sustained knockdown of TTR production in those patients on Patisiran over the trial period compared to placebo. The drug was felt to be safe and was tolerated well. And here we can see the study results. So from baseline, the line going up are those patients on placebo, the purple line, and looking at the mNIS+7 score. So sadly, those patients on placebo continued to deteriorate and their neuropathy got worse. But those patients on Patisiran not only just stayed at baseline, but in many of the patients, their symptoms improved and their mNIS+7 score improved. And this translated into an improvement in their quality of life compared to baseline. And of course, sadly, with the patients on placebo, those patients continued to deteriorate in terms of their quality of life. There was a sub-study looking at the heart side of things, because this was mainly a neuropathy trial, and it showed that Patisiran also had an impact on the heart, improving the biomarker NT-proBNP, which tells us about the strain the heart is under, improvement in the LV, the main pumping chamber of the heart's wall thickness, and the function of the heart improved compared to placebo. Patients were able to walk for longer, and their quality of life improved. Inotersen, which also reduces the production of TTR in the liver, was looked at in the NEURO-TTR trial. Inotersen is given as a subcutaneous injection every week, and it was compared to placebo in this trial. Patients were given either Inotersen or placebo for 15 months, and they again had to be in stage 1 or stage 2. And the primary endpoints were again the mNIS+7 score and also the quality of life score. The safety profile was looked at quite closely, as sadly, quite early on in the trial, a patient died following on from very low platelet count, that's known as thrombocytopenia, which caused a fatal intracranial hemorrhage. The patient hadn't had blood tests taken for some time, which shouldn't have been the case. It was not in the UK, but elsewhere. But once the implementation of frequent monitoring occurred, looking at the platelet count, no serious thrombocytopenia events occurred throughout the duration of the trial, or indeed in the open label extension. Looking at the results from Inotersen, we can see with the mNIS+7 that the blue line tells us that the patients on placebo continued to deteriorate, whereas those on Inotersen had a halting of the progression of the neuropathy with the mNIS+7 score. And this translated to an improvement in the quality of life compared with placebo in those patients on Inotersen over the 15-month period. And then this was shown further in the open label extension study. So again, when I started at the NEC, we didn't have many trials. I was the principal investigator for the Inotersen trial, following on from a meeting that Tharusha Lane and I attended in Japan, now back in 2011. And from then we set about the Inotersen trial, and then the Alnylam trial with Patisiran. And now we've got several trials, the cardiomyopathy trials, AG10, another stabilizer, Vutrisiran, which is the second generation of Patisiran, and now we have the second generation of Inotersen. And similarly with neuropathy trials, we've got the Vutrisiran trial in peripheral neuropathy, as well as the trial of patients following on from liver transplant, and the CRISPR trial, which I understand, John, that is on the CRISPR trial from his comments earlier on Zoom. And that's certainly very exciting because that's actually a gene editing, so snipping out that variant that's causing the problems with TTR amyloidosis of the hereditary type. So we have come a long way in the last 10 years for sure. And I'm very excited that we are going to continue to come a very long way with the trials that we are currently enrolling into, and hopefully we'll continue to see that success for the patients of the future. In conclusion, early diagnosis of hereditary ATTR is so essential for patients to gain the most from the treatments that we have. A structured and personalized approach to the monitoring of patients with hereditary ATTR amyloidosis is needed, with ongoing and frequent assessment of treated patients to inform management decisions. And clearly, a multidisciplinary approach is required for this complex multi-system disease. Thanks very much for your time.